طبعا أنا بس العدد ما أدري بالضبط، بما إنه تغير وقت المحاضرة فعشان كذا ودي يزداد، لأنه almost 65% الموجودين تقريبا أو 60. بس anyway we can start. الموجودين الأغلب موجود. طبعا اليوم راح نتكلم عن HIV. أنا ببدأ طبعا أنا تو راح تناظر الكويشن اللي حطيته لكم بالفاينل إكزام. فايت سيمز إنه ما تحتاجون أعتقد محاضرة. It's so easy الكويشنز. بس I hope it's easy. I think it's easy. بس anyway ببدأ بشكل، خلينا نبدأ بالعكس بالمحاضرة. راح نتكلم عن التفاصيل عن ال HIV. طبعا ال HIV it's a big topic. It's really big. يعني هنا تقريبا we'll talk like 70 slides، بس إنه I tried my best إنه تكون concise و short و direct، لأنه ال HIV is a big topic و the effect of HIV على الميديسين كان كبير جدا. بس I tried my best إنه يكون direct to your level. ومع هذا ببدأ بالother way. خلينا نبدأ بالسمري قبل نبدأ بالاوتلاين. طبعا وش اللي أنا بالنسبة لي أشوف إنه as a student what do you need to know? HIV is a virus. Good. So we know that it's one of the viruses that affect human. Why it's important, this virus? Because it affects the immune system, and that's why it's important. Why it's important? Because it's important because two things. One, the virus itself affects the immune system and the patient gets sick. And because of that, it's still important because it's still there. Why we need to worry about HIV? Because the HIV is still there. Still we have HIV. Still we have new cases. You want to know more? We'll see them in the slide. Do we have it here in Saudi? Yes, we have it. For sure, it's everywhere. So that's why it's important. How it's transmitted, we'll talk about that. The next important point will be how the patient presents with HIV. How do we know HIV? When I need to get worried about HIV. So two things. When those who have like really specific risk factors that they let them exposed to HIV, they are at risk. And once you have these patients, you need to think about HIV. How the patient present? There is the acute viral infection or acute retroviral syndrome. ولا the patient present with the complication of the HIV. And we'll talk about it. So this is how the patient present to you. How to diagnose the patient? Two things. Serology. You check for the antibodies, antigen, or combo test. We'll talk about it. And the other thing, you check for the genetic materials. You check for the RNA, which is called PCR or NAT, nucleic acid amplification test. So that's the way you test for HIV. You diagnose HIV. For sure, we'll talk about what other things we need to check for when it comes to workup. How to treat it? We have antiretroviral now. When this started, like in the 1980s, beginning of 1990s, it was bad because there is no treatment. The treatment started and then getting better, and now it's really patients get one dose of combined antiretroviral. It's one tablet. They do really great. They live their life normal. Some management about the complication of HIV, and do we have prevention for HIV? Is it effective or not? This is also another important point that we'll talk about. So that in a nutshell, what I really think it's important for HIV. So yeah, this is the outline. We'll go through them one by one. It's a virus, retrovirulia. It's called lentivirus. These are the genuses of this family. You don't worry about them. A lot of things in my presentation, you don't worry about them, like the epidemiology, but something just to give you an idea. what's an HIV and why it's important. So you see them like you have, for example, alpha, beta, gamma, delta, epsilon, lenti, but no, you don't see the pointer. So, like for example, the delta, you have this virus, the HTLV1. Here, the lentivirus, you have the HIV 1 and 2, which cause the HIV disease and cause AIDS. As I said, HIV is still important because it's still with us and it's still affecting new people. And this is from the UNAIDS. This was from 2013, and give you the number that with the people living with HIV, and the total number, as you see here, 35 million. And the majority of them, of course, in the sub-Saharan Africa, but you will find HIV everywhere. So in 2013 was 35 million. What about 2019? In fact, the number increasing. So we have 38 million patients living with HIV. So the number increased. This number by itself, I'm not worried about these numbers alone. So if you say like the number increasing, it can mean different things. It can mean just the people now with HIV getting a good treatment and now they're living longer. So the prevalence of the disease will increase for sure. But you have to have other numbers. What the other numbers looking? So still, this is like so 1,700,000. That explain the increase of at least half of these patients. So still we are having newly infected patients with HIV. So that's why it's a problem. Still we have like 700,000 people die with HIV just in 2019. So people still dying from HIV. And this is another important statistics, is like only 68% of adults living with HIV receiving antiretroviral therapy. So you have like 30% of patients they don't receive treatment, and that's why this explains why still we have HIV. This explains why still we have new diagnosis, because those who are not, I mean, you have two parts. Those who like 30% they don't receive antiretroviral, and then there is like part of those who receive antiretroviral, they don't take it very well. The viral load is still high, so they infect other people. And this is just how many adults and how many children with HIV. So this slide, the coming slide, is coming from this report in 2021. Again, it just gives you an idea why still the HIV is a concern, why the HIV is important, why we need to think about HIV. This is the 1.5 million. This is in kind of 2019, 2020. It's the kind of the same number between, this is the new cases between male and female. So still we are getting new diagnoses. This is the distribution of these cases across the globe. Again, it's the same number. This is about the new patient. So still the majority, you're talking about the sub-Saharan region. But one thing, I don't know how clear this figure for you guys, but when you look at the numbers, one important thing that I looked is like how many people. So the first number is how many people acquiring HIV. Then the second number is how many people dying from HIV-related causes. So it's different from country to country, from region to region. But as you see here, for example, here's like you almost like more than 50% of these new. I mean, this is new cases. It doesn't mean these patients who are dying, it just from these new cases. But if you just take it as a ratio, it just gives you an idea how the HIV well controlled or well managed in this region. This one just talk about who the distribution of those who getting HIV. The majority for gay men and men who have sex with men. You have a huge percentage of those, the client of sex workers. Then you have the sex workers, 11%. Then you have injection drug use and as a source of getting the HIV. Then you have the other population and the remaining population, 35%, for a different reason, not included here. Usually when we talk about, especially for infectious diseases, when you talk about infection, usually the WHO and this organization, they, epidemiological wise, they have this target or this goal is if you reach like 90, and they will talk about what does that mean, or 95%, the transmission of any infection will go down and hopefully eliminate the infection. So the trend of the new infection. So the blue line is the newly infected, and the yellow one is people who die from HIV-related causes. So both of them are going down, and then they have a project, hopefully into the curve will go down faster to reach the target in 2025. What is the 90-90 target, or 95-95-95? It's just, so you want, let's say, just take the 90. It doesn't matter, but just take one. So 90. I want 90% of people who know their status among people who. So you want 90% of people with HIV know their status. They know that they have an HIV. Then you want 90% of those taking antiretroviral. And then you want 90% of those have suppressed viral load. So hopefully if you reach these target, or the 95 target, hopefully the transmission will be, the transmission circle will be broken, and then you eliminate the disease, or at least limited the disease in a good way. The reason I put this figure is just for our region here. Still, we're really away from the target. You have 40%, 25, and 21%. The problem with our region is too many things. One, we're not sure about the reporting system. Is it good? Is it bad? Is it accurate? This is one issue. The other issue is we are really, the region is different countries. You have the rich countries, they have resources, they have the poor countries, they have, so it's, whatever we do, still the number will be difficult to interpret. It's yeah. So, but it's still, I mean, for sure, we are, from this figure, we are just much below than other region in the world. This is another figure just to give you, when they did a survey for countries about asking about if the surface of HIV disrupted, and hopefully the good thing will be less than 50%. What they found, it's like HIV testing surfaces was like disrupted in 49% of the countries. We're talking about 111 countries. When about HIV prevention, like 46% that they report like more than 5% disruption. So, and then you have like for initiation of the new antiretroviral, again, you have like here 20% and here 20%, like 40%. So still like a lot of things need to be done for HIV to hopefully reach the goal and control the HIV in a good way. Maybe you heard this before, but there is like staging for HIV. It's not important for us really. I mean, clinically, we don't use it much. They use it for initially for like research, and it just started from stage 0 to stage 3, and then the unknown, and basically based on the CD4 count or CD4 percentage, or if you have age-defining illness. So if you stage 3 will be like less than 200 cell CD4 or percentage less than 14, or you have an age-defining condition. What are these conditions? This is the table for them. You will have, if a patient come with bacterial infection that is multiple bacterial infection, recurrent bacterial bacterial infection. You have like patient with fungal infection, whatever it is, like candidiasis for like weird area like bronchus or esophagus, although it's less likely. I mean, we don't see it much in HIV patient to affect the lung, but you have like fungal infection, like coccidiomycosis, crypto, histoplasma, disseminated histoplasma. This one of the disease, AIDS-defining illnesses. If you have mycobacterial disease, either tuberculosis or avium or other mycobacterial disease disseminated, lymphomas, different lymphomas, Kaposi sarcoma, for example, toxoplasmosis of the brain, BML, again, of the CNS, pneumonia, again, another infection, just regular pneumonia, but it's recurrent infection. So you start to think about, is the patient like immunocompromised? And then one of the things that you think about when you go that way is this an HIV? Is this patient reached the AIDS defining illness or AIDS condition? This is just to give you an idea of the trend. So initially it was like the cases going up. This is about the stage 3, so the AIDS patient. So initially when this was diagnosed, like the people like diagnosed as a stage 3 or AIDS condition, all of them going up, either they're classified or the people who die from it. But then when the medications start to appear and start to use the antiretroviral, these curves start to change, which is like mid-90s. Initially, the medication were really bad. They have a lot of side effects, and they start to improve. But so both curve either classified as stage 3 or AIDS or the death, both of them went down. And for sure, the prevalence will go up because the patient now, we don't diagnose them as AIDS. We just diagnose them as HIV, and they live longer. You give them the treatment, and they live a normal life. And well, Saudi, it was difficult to find really a good report. Initially, there was like a problem reporting the HIV in general, but then the Ministry of Health started to reporting the HIV cases. This one was, but the only one I found was 2014, from 20 to 2014, from 2000 to 2014. As you see, the cases just going up. This is for Saudi nationals. So in 2014 was like 440 cases. I couldn't find any new report, and expected the cases to go up for sure for the next coming years. And this put like an kind of a role for us as a physician. One, to diagnose, think about it, diagnose the patient, treat him well, and then increase the awareness also about how to protect himself. This one, it's the same from the same report, just giving you the red line is the non-Saudis and the blue line are the Saudis. Still the same number for Saudi, but the non-Saudi are more. This one for male to female ratio. When you see the non-Saudis, kind of the average will be 1.5. So every 3 men, you have 2 women with HIV. But this ratio is much more for Saudis. So mostly are men who get an HIV, and the ratio is like 5.3. So every 5 men, you will have 1 female. If we get the averages, it will be around 4. And you can see it like old report or case report, usually find like the husband who got HIV and then this transmitted to his wife or transmitted to his daughters or whatever the case report you have there. So that's why this number is really high. And I think the ratio will change also in the coming years, but and again, initially it was like only 8 centers that give the report of how many HIV patients. That was the distribution where we have most of these diagnoses. So Jeddah was like the most common, and then you have Jazan and Riyadh. I don't know what is Al-Qasim. Like, I think it will be under Riyadh. If there is any cases, we'll go to Riyadh. But again, I think hopefully the future will have good and current report. This is about the people. This one, it's weird. I just found this report about, didn't give me a lot about numbers, but just give me about the people who are living with HIV on antiretroviral between 2013 and 2017. So it doesn't give you an idea about how many new cases of HIV in Saudi Arabia, but just give you that the prevalence for sure increased, and the people who are, and this is about the people on antiretroviral. So that's good. You have a percentage of people that taking their antiretroviral. So that's about the epidemiology, and that's why the HIV is important. How it's transmitted: sexual contact, sharing needles, and parental route. And then you have the the vertical transmission, the mother to baby, pregnancy or birth or breastfeeding. It's not transmitted by air. It's not transmitted by saliva or sweat or tears. It's not transmitted by insects or sharing toilets. I know most of you will know that it's not transmitted by this, but this is for general public because you will have people like worry about these things. So the mode of transmission, the most common, of course, will be the sexual transmission. Which one is the most common? It's the heterosexual transmission, account for 80% of the infection worldwide. But when it comes to the men who have sex with men, that's what MSM, they are more likely to be infected. So when you look at the infection as the HIV as an epidemiology, yes, 80% in heterosexual transmission, heterosexual population, but the MSM like 19 times more likely to be infected with HIV. What are the risk factors? The most important risk factor for that increase the likelihood of transmission? High viral load. This is the most important. Then having other things like if you have a sexual transmitted disease, the risk of getting an HIV will be more. Those with certain sexual behavior, like those who have multiple sexual partners, having sex under influence of drugs, they don't use condom or use protection, the type of sexual exposure, all of them like risk factors to get an HIV. The male circumcision reduce this risk. This is just to give you an idea. So the viral load, if you are here, when the viral load goes up, the probability of transmission go up. And then if you have genital or you don't have genital ulcer, you see the difference. So the blue will be you don't have genital ulcer, but when you have genital ulcer, it's almost, I don't know, double, triple your risk to get HIV infection. Then you have the parenteral, and then you have the perinatal. The perinatal is like nowadays is much improved, using the medication, using the screening for pregnant women, giving the treatment around the time of delivery. So the incidence of neonatal HIV infection, it's really very low. Again, but you need to diagnose it and screen for it. This just gives you the type of exposure and the risk for exposure. So if you get the blood transfusion from someone who's in HIV, it's almost 100%. It's like 92%, I think it will be. So that's clear. But then you have the other risk depend on your behavior, even like when it comes to which sexual interaction, some sexual interaction have more risk to get an HIV compared to others. Like the most common will be anal intercourse to get an HIV, and that's why the MSM will be higher. They have high risk to get the HIV. The pathogenesis so quickly. The HIV, you get the HIV virus. The HIV will come and have its own receptors, like the glycoprotein 120, attached to the CD4 receptor on the cell, and then the virus will get into cytosis and get inside the cell. Uncoat, the genetic materials will be expressed, and you have, as we said, this is a viral RNA. It's a reverse transcriptase. It's a retrovirus. So they have the enzyme, the reverse transcriptase, take the RNA, make it a DNA. Okay, this enzyme, they're important because the medication work on them. So you have the reverse transcriptase or the transcriptase enzyme that take the RNA to DNA. Then you have an enzyme called integrase Let's take this new DNA, put it in the host DNA, just make the integration. And then the virus use the cell. You use our cell to just produce, again, it's just do the regular transcription, translation, all this protein synthesis, and then the new proteins will assemble, and you have a new virus coming, new virion coming outside, and this will go and infect another cells. So what's the natural history of HIV? You get the infection, so you have high risk, patient get exposure, you get infected. It takes weeks. The blue thing, so here in the x-axis on this side, you have the CD4 cell count. The red one, you have the viral load. So the CD4 cell count is going down. The viral load is go up. And it just reach a point at this phase, or this acute phase. This is where the patient can present. I mean, you have a big proportion of patients, they are asymptomatic. They don't know about anything. But then you have other patients who present as an acute retroviral syndrome, just viral infection, just non-specific viral infection. And they improve even without any treatment, without doing anything for them. The CD4 cell count go down a little bit, and then at some point, the viral load will go down because it's kind of controlled, and the CD4 count will improve a little bit. So that's the acute phase. Then you have the chronic phase. Different between patients. It takes some of them takes a few years, 2, 3. Some of them take longer. But with time, the CD4 cell count goes down until you reach a point where the CD4 count really go low, and then the viral load start to go up. And here you start to have like either you start to have the same just general symptoms, but when your immune system go down more, you are at risk of getting other infection or the opportunistic infection, and that's why the AIDS, or you reach the AIDS stage, and you're at risk for all these infection. And patient with HIV or patient with AIDS die not from the HIV per se; they die from these infection. And this is just give you the 3-year progression to AIDS-defining illness. There are two factors, as I said. One is the viral load, and 2 will be the CD4 cell count. So if you look here, those who have CD4 cell count more than 350, the viral load less than 500, so the 3-year progression to reach AIDS, it's like only 1.7%. If you go all the way to the left, those with high viral load, although the CD4 count is still good, but the viral load start to go up and increase, there's like almost 40% of them will reach AIDS-defining illness in 3 years. If you look at the column here, this is the same. If you have viral load more than 30,000, but then the CD4 cell count less than 200, so almost 85% of them by 3 years, they will reach that point, which is AIDS defining. And so if you look at, so let's go back to that. So within 3 years, those with like high viral load and low CD4 cell count, they will reach this stage in 3 years, or 85% of them will reach that stage. Okay, so let's have some question. Where can I? So 34. Let's see who's awake or not. Start. 34, healthy male, presented to you with fever, sore throat, myalgia, skin rash for a few days. No sick contact. He travels a lot. Last week was 3 weeks ago. And when you asked him about his travel, he didn't have fun, but he said, when you ask him more and get more detail, he said, I have multiple sexual partners in the past, including the last travel. So what's the most important next step? Check for HIV, reassure him this is just a respiratory tract infection, counsel him and say, if you are still sick, just come back to me. So actually this one, I put this a question just last semester because I had like an interaction with one of the group that was like just for fun. Yeah, most of you went, yeah, that's for me, that's the main point. When you see someone who has really clear history, high risk behavior, put the HIV in your mind. Either he present with kind of typical presentation for HIV, or just even, and I told the group I was with them this morning, sometimes even if it's just typical infection, it's not related to other things, but he gave me that history of high risk behavior and he was never tested for HIV, I will test him for HIV. Because it's important when you detect, I mean, let's say negative, everybody happy. But if it's positive, he will be happy because you are going to treat him and he will live his life. He will not reach that AIDS stage and he gets sick with a lot of infection. You just give him his medication and he will live okay. So how these patients present, they, as I said, acute infection, almost 30% of them are asymptomatic. And then 70% they become symptomatic. These symptoms varies, different, but these symptoms usually develop like within weeks, let's say 2, 3 weeks, 4 weeks from the exposure or from the infection. So like the question last travel, he was like recently, and maybe he got his HIV just from the last travel. The symptoms can be like mimic the infectious mononucleosis. The patient will have like fever, again, non-specific fever, malaise, myalgia, maybe night sweat and weight loss, but maybe just fever and rash, maybe lymphadenopathy. Some of them might complain of sore throat or some ulcers. They can have some rash, generalized rash, nausea, diarrhea, anorexia, again, weight loss, headache. So most of them, they're not really specific, but just non-specific symptoms, viral illness. Again, the night sweat or the weight loss is kind of more aggressive than other viral infection. But again, when you take history and you find like risk factors, then you need to think about HIV. So that's one, the acute presentation, acute retroviral presentation. Then you have the other things that either it's a complication of HIV, either non-infectious or infectious. I put them like for you guys, I mean, if you ask me, I want you just to go through them once. No way you will memorize all of them because again, the students always ask me, do we have to know every details about these tables? No. But just to give you an idea that HIV patient, because of their immune status, they are at risk of these complications. So when we take it like neuropsychiatric, non-infectious, they can what they call it hand syndrome. They have some neurocognitive. They are at risk of primary CNS lymphoma. They can have some psychiatric illnesses. They can have radiculopathy, infectious complication. Toxoplasmosis is the first thing you need to come to your mind when you think about HIV. Crypto, it's a cause of that. Then CMV and BML. And usually the BML or CMV, it's like will be really in patient with low CD4 cell count compared to the other. But all of them, when the patient reach like the kind of the low immune status with low CD4 cell count. Head and neck, retinopathy, gingivitis. When it comes to infection, retinitis for different causes, CMV, toxo, HSV can cause the acute retinal necrosis. Patient can present with otitis, sinusitis, recurrent sinusitis, recurrent otitis. They can present with invasive fungal infection. Cardiovascular, they can present with cardiomyopathy, or they are at higher risk than general population for cardiovascular disease. The infectious complication, myocarditis, pericarditis, either CMV or fungi or mycobacterium or toxo. Pulmonary, again, they are at risk of pulmonary hypertension, HIV-related pulmonary hypertension. They can have interstitial lung disease. They can have lung cancer, either lymphoma or Kaposi sarcoma. The infectious complication will be pneumonia or pneumonitis. It could be PCP, one of the most common things that can affect those who are immunocompromised. You see it more with people with immunocompromised, including HIV patients. They can have CMV. We don't see it much, but it can happen. Invasive fungi or toxo. Pulmonary TB is an important one with HIV patients. Gastrointestinal. Again, they can have enteropathy, they can have lymphoma, Kaposi sarcoma, viral hepatitis. Then the infectious, I don't know why viral hepatitis is here, it's not here. So it's need to go there. Candida, CMV, HSV, bacterial enteric infection. They can have protozoal infection, so they present with chronic diarrhea because they're more prone to protozoal infection or presentation of protozoal infection. Renal, again, they can present with some nephropathy called HIFAN or HIV-associated nephropathy. They can have other things also. And when it comes renal and genitourinary infectious complications, sexually transmitted disease, it's an important both way. If you have a patient with HIV, one of the things that we do in ID or in HIV clinic, we check them regularly, especially if they continue to be at high risk. We check them regularly for sexually transmitted disease, like every 3 or 6 months. We check for gonorrhea, chlamydia, all these things. But also you see it the other way. If you have sexual transmitted disease, you need to think about HIV. And I saw patients like this. The patient went to like 2 urologists. He's young male who just, they treated him with antibacterial for for UTI, or even if they think about sexually transmitted disease, they didn't even check for HIV, which is simply the reason. I don't think they thought about HIV. They didn't think about it, and that's what happened. If you think about it, you don't test for it. If you don't test for it, you're not going to diagnose HIV. And for me, this is the main point for you guys: is just to think about it in the right clinical setting. Again, you have endocrine. Sometimes they have lipodystrophy. They have a lot of dysfunction: thyroid, pancreatic dysfunction, hypercalcemia, some metabolic abnormalities. They have problem with their weight before or after they start taking their medication. Adrenal gland can be have some infectious complication or infectious infiltration like CMV, mycobacterial, or invasive fungi. Again, most of the infectious complication and most of the non-infectious depend on the stage of the patient, depend on how long he was diagnosed with HIV without treatment. So all of these complications, again, this is historical complication. Maybe nowadays, if you have a new study, you are not going to see all of these complications, both infectious and non-infectious. Because if you diagnose the patient early on, you treat him very well early on, he has like viral suppression, then a lot of these complications will not happen. And so on. Hematology, anemia, they can have thrombocytopenia, they can have HIV-associated TTP, lymphoma, there is something called primary fusion lymphoma, or they have Castleman's disease as a non-infectious complication. When you look at it, infectious, the bone marrow infiltration, either CMV, mycobacterial. So an HIV patient can present to you with pancytopenia, then you need to think about infectious complication affecting his bone marrow. Dermatologic, they can, as I said, they can present with rash, they can have eosinophilic folliculitis, they can present with what Kaposi sarcoma. They have lesions like whatever it is, like in their feet or legs or their throat. It's just consistent with Kaposi sarcoma. Or infectious complication. They can have molluscum contagiosum, like disseminated fungal infection, Bartonellosis. Cat, yeah, the group for today. There is a cat, an HIV patient. So this is another question. Let's do the C and D. 38 admitted to the hospital with increasing weakness of the left hand, arm, and headache, and fever for 1 week duration. So he have like CNS manifestation. Medical history significant for AIDS. He reports non-adherence to his antiretroviral therapy for the past 2 years. You did the neurological exam, and you notice left upper extremity weakness. The lab shows CD4 cell count 66, negative cryptococcal antigen. You sent for toxoplasma serology, and the IgG was positive, but the IgM negative. Non-contrast hit CT shows a single lesion in the right parietal area. Which of the following is the most likely diagnosis? CNS lymphoma, crypto, toxo, or PML, progressive multifocal leukoencephalopathy? Okay. So most of you went to the right diagnosis or the right option here. When you have an HIV patient presented with CNS infection, yes, lymphoma isn't the differential for sure, but you need to think of toxoplasmosis. And usually the way we approach it, we treat for toxoplasmosis. If patient not improving, we start to thinking, is this a lymphoma? It's not toxoplasmosis. PML usually present differently. You have multiple lesion when you get MRI. The crypto is still possible, but again, the cryptococcus antigen is negative, and the sensitivity of the cryptococcal antigen is really good. So once it's negative, it goes really down in your differential. So these are the diseases that can affect people with living with HIV. It will be based on the CD4 cell count. So if you have a high CD4 cell count, these are the you have bacterial infection that I mean, recurrent bacterial infection. You can have TB or other viral infection like HSV, female patient with vaginal candidiasis. You can have Kaposi sarcoma. Mostly we see them like when the CD4 cell count is low, but you can see them in patients with higher CD4 cell count. Then when you go lower, you will have the pneumocystosis, you have toxo, crypto, coccidioides, and crypto. Again, this is, we don't have, as far as you know, we don't have it here, but this is like in different areas. When you go lower, like in the range up to 150 or to 200, you'll start to think about mycobacterial APM complex or disseminated MAC infection. In the right area, geographical area, histoplasmosis. You start to think about CMV retinitis if the patient presenting with visual complaint, CNS lymphoma. This is really important because, for example, if you have a patient presenting with shortness of breath and his CD4 cell count 500, PCB or pneumocystis, it will be low in your differential. Usually, most of the patients with PCB, they will come with the CD4 cell count less than 200 or less than 300. So when the CD4 count is high, yes, it's still in the differential, but it's low in my differential. I picked a few of these common infectious complications. One of them is PCB, pneumocystis pneumonia. Initially, it was pneumocystis carinii. That's why it's PCB. It was carinii, the C. Then, as they do all the time, they change the names. So the new name will be pneumocystis urfetzi. But again, as a diagnosis, as a pneumonia, still the PCB, we call it PCB, but the organism, we call it, it's different now. It's pneumocystis urfetzi. It's a fungus. It's everywhere. If we are healthy, immune status is okay, you don't worry about it. But once your immune status is bad, you can get this infection. It can happen as either new infection or latent reactivation. Usually the risk factor, if the CD4 count less than 200. If you have a patient, I give you a scenario, I said, this is a patient presenting with shortness of breath, and then I tell, you do your exam, you find oral thrush. They found in studies that usually patients with BCB, they present with oral thrush. So finding the oral thrush can give you a clue that this is a PCB. A patient with a prior BCB, it's also a risk factor to get another BCB. That means he's exposed. He can get the infection again as a reactivation. How it's present? Usually as a subacute presentation within weeks. Dyspnea, fever, cough, non-productive. They might have chest pain. When you do the exam, they might have like desaturation. Chest X-ray, it can range. It can be normal or can show the classical picture of PCB. What's the classic? It's bilateral. They call it bilateral butterfly pattern interstitial infiltrate. You see the infiltrate bilaterally, but it can be normal. Yeah, so if you have a chest X-ray that it's normal, doesn't mean it's not PCB. Still, it can be PCB. Usually, one thing we do, we get an APG for them to see the degree of hypoxemia. Why this is important? Because the management can affect the management. The diagnosis, usually the standard is the microscopic visualization for definitive diagnosis, but then you have other tests. You can do it from the sputum. You test for PCB. I didn't include it here. I don't know why. I need to update my slide. But you can check the diagnosis for PCB without microscopy, without the visualization under the microscope. Usually the treatment is the Bactrim or the trimethoprim sulfamethoxazole. If you check the ABG and you find that partial pressure of oxygen less than 70, you add steroid for them. That it gives you an idea that the patient is severe infection, and the steroid gives them benefit. They improve faster. They will be less for the risk of complication will be less. So you give them steroid. So you do it either if the saturation is less than 70 or if the A gradient more than 35. Go ahead, Abdullah.
بس دكتور نقطة اللي diagnosis قلت مو بلازم مايكروسكوبي لكن وش نستبدله فيها يمكن برونكيل لافاج
لا احنا من sputum you get an induced sputum and you test for BCP.
واضح
في يعني طبعا احيانا بالسبيوتم طبعا على حسب السنسيتيفيتي. احيانا مثلا if I'm thinking about BCP وسبيوتم ما induced sputum ما جاب لي نتيجه, you do the lavage. I will call the pulmonology, get the lavage and test it for BCP. غالبا حاليا المولكيولر في طبعا على حسب المستشفيات. انا اقول لك مو بلازم مايكروسكوبي, فيه البي سي ار مثلا. فبعض المستشفيات الكبيره يسوون بي سي ار تيست فيعلمك في بي سي بي ولا ما في بي سي بي. طبعا مش تدخل على مشكله البي سي ار معناته هل هو colonization, بس اذا patient presented with like typical picture I will test it for PCR. البي سي ار positive خلاص I will treat it for BCB.
واضح دكتور, شكرا.
لا هو البي سي ار من سبيوتم. انت تاخذ السبيوتم تسوي البي سي ار عليه, فهو من سبيوتم نفسه. البي سي ار افضل طبعا. يا دقيقه بس. Okay, so what's next? Yeah, the other disease we have for the HIV or the complication will be TB. I will talk about it more like in the lecture tomorrow, inshallah. It's really important. It's really important to test for if you have a TB patient, check for HIV. If you have an HIV patient, check for TB. So you have to do them both, whatever the patient who's coming to you either with TB or HIV. I'm just checking فيه طبعا فيه البي سي ار وفيه الاميونوفلوريسنت, لكن في اشياء ثانيه حتى again تعتمد على حسب. مثلا في البيتا جلوكام, بس ما ودي ادخلكم بالتفاصيل هذه. الفكره انا بالنسبه لي يعني each one of them BCB is kind of I can take like 20 minutes talking about BCB. which one الموست سنسيتيف will be PCR، بس تخاف مثلا من الكولونيزيشن. فيها احيانا الاميونوفلوريسنس بالبي سي بي. اعتقد مثلا المستشفيات اللي هنا، اللي ما ادري عن المستشفيات الكبيره بالرياض، بس قد يكون الموجود بالتخصصي هنا تلقى الاميونوفلوريسنس، ما تلقى طبعا من السبيوتم، اجيب تاخذ السامبل من السبيوتم وتست السبيوتم. بالنسبه لي اللي يهمني انك تعرفوا الان بالمرحله هذه انه if a patient with HIV or immunocompromised patient in general with shortness of breath, respiratory symptoms, yeah, you think about the typical infection, typical bacteria, again, different situation, but you have to think about other things. Which other things? TB is one of them. Fungal infection like PCB in our region, PCB. If you are in different region in the world, depending on which region, what is more common in like fungal infection or other atypical bacteria. So you have to think about it. For HIV, I want you to think about PCB, test for PCB, and treat for PCB. You have the Mycobacterium avium complex. Again, this is usually we see it if the CD4 cell count less than 100 or less than 150. More common, really, you start thinking of really low CD4 cell count less than 50. The patient will present kind of disseminated infection. They will have like pancytopenia, they will have diarrhea, they will have abdominal pain, they have like night sweat, they have fever. So it's kind of disseminated infection. You can have like also hepatosplenomegaly or diffuse lymphadenopathy. You need to test for it from blood, from bone, from wherever you can test for it and try to diagnose it. And the treatment will be clarithromycin and ethambutol. And the duration will be different. But again, you're not going to treat this, somebody else will treat, but this is the kind of few points about it. Other one, the one you guys answered almost all, most of you answered correctly, the toxoplasmosis. It's caused by reactivation. So I tried to put the IgM negative, but it doesn't matter. The patient with HIV or immunocompromised, they get the disease by reactivation of the toxoplasma. And usually you see that when the CD4 count is like less than 200 or less than 100. It's the most common cause of CNS mass in people living with HIV or people living with AIDS. They present as any CNS mass. They will have fever, headache, seizure, focal deficit. You need an MRI to diagnose as CT or MRI. I will go with MRI better. Definitive diagnosis will need a biopsy, but usually I'm not going to do a biopsy for these lesions. Usually, as I said, usually when if I have an HIV patient with really low CD4 count and both have IgG positive, I will treat him for toxo. And usually you treat for like with permethamine, sulfadazine, leucoferin. It's a combination. You treat them for kind of 2 weeks. Usually the progress, you want to see improvement by 2 weeks. If you don't see the improvement, 2 weeks, 3 weeks, then you start to rethink. Maybe it's not toxo. Maybe it's CNS lymphoma. And then you go like, I need a biopsy. So when do we test for HIV? As I said, when you have the clinical or the right clinical setting, the patient is at risk, then I will test for it. When it's fake, when you don't know, test for it. Patient having an acute viral infection with high risk behavior, I will test. Having complication that only we see it in immunocompromised patient, I will test for HIV. Sometimes patient can just, they will say like, either they don't give you really clear history or they give you fake history with maybe some really long time ago sexual interaction. Sometimes the patient will be reluctant to give you all the details. If he just give you the hint, I will go and test for it. Recurrent infection, that means the patient is immunocompromised. One of the things you think about is HIV. I will test for HIV, and then you will test for other things. TB, as I said, hepatitis B virus, HSV, other sexual transmitted. As I told you guys, if you have sexual transmitted disease, I will check for HIV. If you have TB, I will check for HIV. HBV and HSV, the reason is the medication can affect the treatment, especially for HBV. The treatment, when you start the treatment, you don't want partial treatment for HIV. So you don't want to treat HBV and you miss that diagnosis of HIV, and then you get this treatment for the hepatitis B will be partial treatment for the HIV. and then the HIV will be resistant, and you need to you will be in trouble, like getting another regimen for him. Again, high risk behavior like MSM, sex worker, IV drug use. If you have a known exposure or high risk exposure, all pregnant women now they screen them. If you have a sexual assault, the victim of sexual assault, you screen them. Occupational exposure, again, the donor and the sometimes the patient request is another reason to test. You can have patient he comes and he wants test for HIV. You get history, he's not at risk, but maybe he's hiding something. He doesn't want to tell you that he had something, but he says, I'm worried, I read about it. Yes, I will test for you. If it's negative and he keep coming back for HIV, then you have to have a different discussion with him, because now he's more anxious and worried and occupied with the HIV more than really the risk that he had. But at the beginning, I will test for it. I had a patient who's he had actually sexual history, but it was a long time ago. But he like tested himself over the last 3 years. I don't know, it was like 6 times or 7 times, and all of them negative. So he came to me, just want to like, do I need another test? Is it an HIV too? And he read a lot about it. He's worrying about it. He's like really, his life is really bad for the last two years. I reassured him. I said, I can do it for you, but if you have all this result, and he showed me the result, you don't need any more testing. If you don't have any new exposure, and he like swear, I didn't have anything for like 4 years. I said, okay, that's fine. All these tests, if they are negative, you don't need to repeat or worry about it. Okay, we need to move fast. The patient who presented to you earlier, he wanted to discuss his lab test. The lab results showed white blood cell, white blood cells 2,300, mostly lymphocyte. HIV-1 antigen antibody combination assay, serology test, was non-reactive. So which of the following is the most important step? You'll check the CD4. I want to see how low they are, or you do the Western blot, or you do the nucleic acid amplification test, the NAT or the PCR, or you just reassure him. So yeah, you have a sexual behavior before, but giving that lymphocytosis and giving the test is negative, which is really good sensitivity, I would just reassure this is most likely infectious mononucleosis. Yes, sir. Whoever asked, yes. هنوريكم response. هذا response. فالحين continue voting for another 10 seconds. Okay, good. So yeah, the majority went with the C. I mean, there are few don't vote. Either they're sleeping or they don't care. But yeah, it will be the PCR. Yes, يا ما ادري بريدي بس نسيت اسمك الاول. You have a question or move on? ما ادري ما اقدر اشوف من اللي يرفع ايده. في احد عنده كويستشن ولا امشي؟ هلا؟
ما في احد.
ما في احد. طيب let's go. طيب. So yeah, again, he has a high risk behavior. I'm worried about HIV. Even if the first initial screening test is negative, I will check the PCR for him or the nucleic acid amplification. So this is the serology test. Nowadays, we do the 4th generation. This is just historical view for you guys. Started with 1st generation, 2nd, the 3rd, and then the 4th generation. It's a combo test. which is antibody and antigen. You check the antibodies for the HIV, and you check the B24 antigen. When you get the infection, you take like almost 10 days to 2 weeks for the HIV RNA to go up. And then after that, you have the antigen, the B24 antigen will go up. And then after that, you will have the antibody. So initially, when you had the first and second generation, if you test, the sensitivity is low. You will miss all the patients in the first 2 months. These tests start to improve. We have the fourth generation now. If you test the fourth generation test or the combo test, the one I told, the one in the question in the previous question, usually if the patient has the infection like in the last, let's say, 4 weeks, most of the time will be really a good sensitivity and it will be positive. But if you have a patient with really high risk and this test is negative, then I will go for the more sensitive test, which is trying to detect the RNA, the HIV RNA, which will be the PCR. Usually, as I said, the patient usually present like within 3 weeks of their infection. So usually the patient during this 10 days, they're asymptomatic. So that's why the PCR is the most sensitive. The most sensitive test, and usually you will detect the patient with HIV with that. This is the algorithm for it. If you think about HIV, you do the combo test, the fourth generation. It will test for both 1 and 2, antigen, antibody, immunoassay. If it's negative, you don't need to do anything more unless this is really an acute and you're worried about his risk. So then you go to the PCR. If it's positive, then you go through more details about just to detect if it's called the differentiation immunoassay. هل هو HIV1 هل هو HIV2 إذا لا negative then you go to the NAT اللي هو nucleic acid amplification test عشان نشوف هل هو HIV1 ولا لا. فبasically التست once you think هذا اللي قلته بالبداية, you think about HIV, you do a combo test. It's negative and worry about HIV, do PCR او النات. هو نفسه ترى نفس الاسم, بس انا احيانا ينقال له بي سي ار واحيانا ينقال له نات. هو البي سي ار سمبلي اللي هو تاخذ النيوكليك اسيد وتسوي له امبليفيكيشن. Let's do another question for you guys. B, C, D. So, 32 years old woman treated a week ago for vaginal discharge. I don't know what's the reason, but he tested HIV1 and 2, the combo test, and came back reactive. Subsequent test, differentiation test, and nucleic acid were ordered, and both were negative. The patient is asymptomatic. She's married. No extramarital relationship. So what do you want to do? No further testing. You want to see the T cell subset. You want to see the CD4, CD8. You want to do a Western blot. You want to repeat the test like within 3 weeks or 4 weeks, just in case we missed it. طيب نعطيكم الأجوبة عشان الباقيين يغشون. Oh, what's happening? Okay. Yeah, I usually have fun when you. Okay, when you show the answer, the people go with the most common, although sometimes it's not the accurate answer. But here, as you guys see, it kind of distributed between A and B, A and C and D, but the majority went with A, which is the correct answer. You have a low-risk patient. Yes, she has some vaginal discharge for whatever reason, but she doesn't have really high-risk behavior. She's married. There is no extramarital status. And then you get a PCR, and the PCR is negative. And this was a week ago, this vaginal discharge. يعني حتى هذه كل الإعدادات هذه جلسنا الآن لنا أسبوعين بالتست هذا or 2 to 3 weeks. For all this, give you just this one is just false positive. The first test, the combo test, is just false positive. It doesn't mean infection, because the most sensitive will be the nucleic acid amplification test or the PCR, and was negative. So you don't need to test it. The one caveat here is like, yeah, she's married, she doesn't have any extramarital relationship, but we didn't ask about her husband. So this can give you like more. I mean, if I will make this question in a better way, I will either say she's not married now and there is no sexual relationship، او اني اقول انه الhusband was tested or whatever. يعني لانه you will be worried about the husband was recently infected and he just gave her his wife the new infection. But the correct answer here will be no further testing. Again, if the husband addition was there in the story, then will be kind of more accurate. No, اللي سوى له التست ما ادري ليش سوى له التست. He just didn't take history ومتحمس يعني. And that's the point of the story يعني. Now you treated illness again, depend on the history. The history is important. When you diagnose, you need to do counseling about the patient, how the HIV transmitted. Yes, now he's diagnosed, but also to prevent transmission to other people. If it's not diagnosed, let's say you have a patient who's at high risk, but he's still like in high risk behavior, but he's not HIV. You can talk to him about prevention. If diagnosing a patient with HIV, you talk about prognosis. What's the difference now? Need to take medication. The medication will let him live his life in a kind of a normal life. Once you diagnose the HIV is positive, you do all these tests. I will check for the viral load. If it's not done yet, I will check for the genotype to see if this virus is resistant to some antiretroviral. I will check for the CD4 cell count. I will check other labs, CBC, CMP, lipid profile, urine analysis. I will check for quantiferon for the TB, as I said. I will check the hepatitis and toxoplasma serology. I will check for syphilis. I will check for STDs. You check all of them, because once he's at risk, maybe he has other things too. The treatment, this is kind of the same I showed you before, the pathogenesis, but just that the classes of medication we have based on these enzymes. We have the reverse transcriptase, so we have the NRTIs and NNRTIs. We have the integrase, then we have integrase inhibitors. We have the protease, then we have the protease inhibitor. And then when the virus come and attach to the receptor, we have the entry inhibitors. A lot of classes, as I said, you have the nucleotide reverse transcriptase inhibitors, or NRTIs. You have the non-nucleoside reverse transcriptase inhibitor, NNRTIs. Different regimen. This is the recommended, this is alternative. I'm not going to ask you about medication. I want you to read them once in your life, just for your own. What's important for me, again, I read this multiple times. I want you to think about HIV, diagnose HIV, know the complication of HIV that I gave you. Medication, just read them once. There is antiretroviral regimen. If you're interested, go in details about them. Nowadays, the most thing that we use is the integrase inhibitors, which is raltegravir, dolutegravir, bictegravir, as the most recommended right now. The protease inhibitors, we use them sometimes, but they have a lot of drug-drug interaction, and this is one of the things that you need to keep in mind when you treat an HIV. Usually the one who will treat HIV will be an infectious disease, so even if you're resident or if you're a consultant in different specialty, you're not going to start treatment. So that's why I'm not worried about, like, I don't want you to ask you, it's really above your level, and even if you're a consultant in other areas. But it's good to be familiarized with the classes and the names for your own knowledge. I mean, yeah, sorry. These things just like infrequently used. They just, historically, they are there. Nobody used them, unless you are really in a different area in the world that only they have these agents. But I don't think you will be tested or see them in your life. Another question, 25. Just diagnosed with HIV. He's totally asymptomatic. No history of opportunistic infection. Physical exam, totally unremarkable. Full physical exam. Lab CD4 cell count 600, and HIV viral load is almost 3,000. Sorry. What's the approach next step? Start antiretroviral today, or just wait for 2 weeks, or start antiretroviral therapy once the CD4 count get less than 350, so the patient will be more risky to get the opportunistic infection, or no need for treatment because the patient is asymptomatic. Let's hide him. Good. Right. So 28 are sleeping, 27 are sleeping. So the majority start antiretroviral today. That's the correct answer. You need to start it. Recommended all individual, regardless of the CD4 count. The reason I put the question, just in case you had a lecture from before, I don't know when, but before was like, there was like that notion that you don't start antiretroviral until like the CD4 count drop below 500 or below 350 or something. But this, I don't know when this changed, but now you just, regardless of CD4 cell count, again, you treat the patient, you won't suppress viral load because you will decrease the transmission, even if the patient is symptomatic, even if the CD4 cell count is good. You want to decrease the transmission, you want to, so help the society as a whole. You want to prevent the complication, either AIDS or real infectious complication, or like non-infectious complications that's related to having the virus in your system replicating and causing all this mild inflammation and affecting your body. It's an important thing to assess how a patient is ready to start the antiretroviral. That's why the education is really, really important. We start medication, and you just adjust to your medication and continue to take it. And it's a lifelong treatment. You treat it for life. It's just a chronic disease. Hopefully, at some day, in the future, we'll have for it. But right now, you just take it all the time. A lot of improvement now in the HIV treatment. So here's like what to start. This is, again, I put the link here for anyone who's interested. It's like I don't know, 200 pages of guidelines, but this is like the most common, or the recommendation goes for HIV if the patient is, we call it treatment naive, أول مرة يجيك ما سبق عالج. This is the recommendation. Bictegravir, tenofovir, and emtricitabine. These comes like one tablet. You take them once daily, and that's it. All these like good, reasonable treatment as a first line, and then you have other treatments or other options that you can use. A lot of improvement happened in the last few years. Now we have even injectable antiretroviral. The patients come and get an injection once every 2 weeks. And there's like some drugs that they still, like in studies like phase 2 or phase 3 trials, they just give them for like once a month, and you're good. You just come once a month or once every 2 weeks, get the injection, goes home. He doesn't need to take medication every. So, and this, you can see it in both, like for treatment and for prevention. It will take time until become like the standard of treatment or the standard of care, or the recommended. It will take time, but right now, even like in phase 3 trials, they show their efficacy. الصوم بدأ يأثر. Anyway, how to choose the ART regimen يعتمد على الافيكاسي على حسب الريجيمن، يعتمد على البيس لاين ريزيستنت، عشان كذا يسند الجينوتايب، التوليرابيلتي، بعضهم فيها سايد افكت على حسب البيشنت، على حسب الاذر ديزيز اللي عنده، على حسب وتمشي مع الوقت تشوف هل هو tolerate this regimen or that regimen. Long term toxicity, an important thing, drug interaction, especially if you are using protease inhibitor. make sure غالبا نفضل ان تكون شيء 1 بيل ياخذه مره باليوم فتقلل البيل عليه، او اذا عنده other infection. Good question. I'm not sure. I don't know how much. I think it will be expensive, more expensive than others regular medication. بس بصراحة ما أدري كم. لأنه هنا غالبا اللي يعرف إنه حكوميا يوفر لك حقه. بس كم إذا بتشتري out of pocket ممكن نشيك. طيب why the regimen fail? There are three factors. either المشكله في الريجيمن اللي انت اخترته، يعني مثلا في drug drug interaction كذا الانتي ريتروفايرال ما جالس يشتغل، او في نسميها low genetic barrier to resistance. على طول في بعضهم تعطي الميديكيشن الفيروس find a way to be resistant to that regimen. احيانا يكون في بعض الانتي ريتروفايرال محتاج انه تاخذه قبل الاكل، ما يكون في dietary requirement، ما تشربه مع ايش، فبيكون الابسوربشن حقه سب اوبتيمال، فيكون عندك ريزيستنت بعد في الريجيمن فيل. في الاتش اي في ريليتد فاكتور انه يكون عنده اصلا اذا if you didn't test for the genotype ممكن الاتش اي في فيروس اللي جاو resistant to some most common things the most recommended or first line recommended treatment. البيشنت ريليتد انه مثلا الموست امبورتنت وان will be adherence، انه ما بجالس ياخذ العلاج حقه، عاد سواء عشان السايد افكت، عشان انه كثير الحبوب اللي جالس ياخذها، عنده سايكو سوشيال بروبلم، عنده سبستانس ابيوز، whatever the reason, but he's not taking his medication. Yeah, this is an important question. I will go with 27 years old male diagnosed with HIV recently. He reports recent exposure to active TB case, but he's asymptomatic. Chest X-ray is normal. You did the screening test for TST and was 4 millimeter in duration. Which of the following is the most important next step? You repeat it in 4 weeks. Start isoniazid and pyridoxine for latent TB. Start full treatment for TB, and no further tests. Okay, so majority they will treat you for latent TB. بعدكم قال بعيدة. Next second will be start for active TB. You didn't start for active TB unless you diagnose active TB. We'll talk about it tomorrow, but it's this is the only different thing with HIV patients. So usually those who are kind of immunocompromised or HIV patient or have recent exposure, the limit is more than 5. So if you have more than 5, it will be positive. This one is negative. The test is negative. But because he is an HIV patient and he has a recent exposure to active TB, so you don't worry about you don't need to worry about if the screening test is positive or not. You will treat him for latent regardless. So that's the point of this question. And most of you answered correctly. So either الoptions حقاتي سهلة خيارات، او انه السؤال سهل، او انكم مره خطيرين. البرايمري بروفلاكسس كان قبل البروفلاكسس كان يستخدم الازيثرومايسين مثلا للماك انفكشن. هذا طاح من الجايد لاينز الحين. The only treatment we give prophylaxis لما CD4 count less than 200 نعطيهم باكتريم. هذا يغطي لك نيوموسيستس ويغطي لك التوكسوبلازموسيس. زي ما قلت التريتمنت فور ليتنت تي بي، البيشنت اللي ما عنده active infection and positive screening, you will treat him for latent TB. البيشنت اللي عنده close contact with infectious TB regardless of the screening test, برضه you treat him for latent TB. The last thing here, there is something called immune reconstitution inflammatory syndrome or IRIS. باختصار تبدا الانتي ريتروفايرال تريتمنت للبيشنت، يتحسن الاميون سيستم عنده، تطلع الانفكشن اللي متغبيه، يعني خليها ببساطه. طبعا فيها تو ثينجز، ايذر بارادوكسيكال اور انماسكينج. الانماسكينج اللي هو تطلع الانفكشن اللي كانت موجوده، يعني يجيك اتش اي في بيشنت خلينا نقول عنده تي بي، but he didn't present with TB. You start antiretroviral يبدا يكحكح عليك ويبدا مدري ايش، ولا يبدا اذا كانت سي ان اس تي بي ولا سي ان اس كريبتو ولا ايا يكن. ف you do الايمجنج، تلقى الفايندنج وتلقى you do your work up، تلقى الدياجنوز. فهذا unmasking. فالاميون سيستم awaken again, start to work, recognize the infection, fight against this infection. The patient is symptomatic. So this is unmasking. البارادوكسيكال اللي هو worsening للانفكشن، يعني احيانا يجيك البيشنت خلينا نقول عنده تي بي وعنده اتش اي في، ما ادري انا بتكلم عنها بكره ولا لا، بس مثلا التي بي مع الاتش اي في we don't, if the patient CD4 cell count is okay, we don't treat الاتش اي في. treat التي بي for a period of time، بعد اسابيع نبدا الاتش اي في تريتمنت، علشان ما نحصل البارادوكسيكال ايرس هذه اللي هو وش فكرتها، انك انت تعالجهم جميع، تعطيه انتي تي بي مثلا، خلينا نقول التي بي، تعطيه انتي تي بي وتعطيه الاتش اي في الانتي ريتروفايرال، عقب اسبوع عقب اسبوعين السيمتومز حقته وورسنج. فالان هل التريتمنت حق التي بي باد؟ not necessarily. simply it could be paradoxical iris اللي هو لان الاميون سيستم صحى و start fighting ف his symptoms get worse. لكن your treatment is okay. It's really tough diagnosis, but it's good to know about this entity here. Again, the most common pathogen associated with iris will be TB, MAC, PCP, Cryptococcus, CMV, PML, HBV, HHV8. What else? Wow, it's a long lecture. أعتقد the last thing. Prevention, the way you do it is what's the mode of transmission? Sexual transmission. Then do the prevention through this way, like sexual education, using condom, circumcision. We talked about it. If you have sexually transmitted disease, treat them. So you try to prevent your risk of getting the HIV. Parental transmission, for those who have like IV drug use, they do something called needle exchange programs. They have addiction programs. We do now having like the blood products screening. Vertical transmission treatment, screening the mother and treatment for them, and treating the baby also during that time, and they avoid the breastfeeding. خلنا ننط هذه شوي. Prevention intervention for infected patients. Yeah, so how to prevent it? You start effective treatment for him. We talked about it. Screening for other STDs عشان تمنع الانتشار للأذر، والكونسلنج حتى سواء مثلا couple or married people. بعدين فيه البري اكسبوجر بروفيلاكسيس وفيه البوست اكسبوجر بروفيلاكسيس. Yes, we do prophylaxis للبري اكسبوجر. إذا جاك واحد عنده high risk behavior مثلا, sometimes we give them antiretroviral prior to the exposure. But the most important thing, we do the baseline assessment, check ال HIV, لأنك ما تبغى تعطيه partial treatment وهو عنده already HIV. فأنت الحين بتخلي ال HIV عنده resistant. بتسوي له البيسلاين HIV status، تتأكد إنه نيجاتيف، تبغى renal function لأن الميديكيشن affect renal function، تبغى تشوف ال HBV status حقته. Once all of these negative, you start him with treatment that he take daily, because if he's still on high risk to get an HIV, وخلاص تعطيه الميديكيشن, adherence to this medication, go with his life. But you need to bring him back like every 3 or 6 months to check the labs again to make sure he's not becoming positive. لأنه أحيانا ياخذونه they're not adherent to their medication, أو يبدو مثلا because of the side effects ياخذونه متى ما بغوا. فإذا ما رجع عادي يصير عنده ال HIV, he acquired the HIV وستيل جالس ياخذ partial treatment لل HIV, فيكون عنده resistant. فالآن a big proportion of the current regimen is the TDF واللي هو التينوفير والانتراسايتوبين. فالآن you lost this option just because you didn't know about the diagnosis. أنا ما أدري صراحة أكلمكم وفاهم الكلام, يعني كلام واضح, بس it is what it is. You do regular HIV and sexual transmitted disease testing. البوست exposure prophylaxis في occupational non-occupational regardless of them, the treatment is kind of the same. It will be no, it's not the same. I mean, it's still the same. The TDF and emtricitabine, tenofovir and emtricitabine, plus raltegravir or dolutegravir. فمثلا واحد نون اوكيبيشنال هاي ريسك وخايف من الاتش اي في انه كان مع واحد اتش اي في بوزيتيف فتبدا التريتمنت تعطيه فور 4 ويكس until you get the test back انه نيجاتيف ولا ايا يكن. الاوكيبيشنال اكسبوجر needles or whatever you test for HIV but you test for other things. HIV you test for HPV you test for HCV وتبدا الانتي ريتروفايرال اسهم خلاص. I will send the lab واذا انا ادري ان السورس حق الاكسبوجر HIV بوزيتيف ولا ما اعرف السورس ما تبغى تاخذ المخاطره يستخدم الانتي ريتروفايرال تعطينا ذا سيم ريجيمين هي اللي هو التينوفير امتروسايتبين مع الرالتوجرافير والدولتوجرافير for another 4 weeks وتعيد التستنج. طبعا تعيد التستنج هذه مينلي فور واحده فور الاتش اي في بس also for the other viruses. Yeah, this line, this website for just the AIDS timeline. Thank you. Any question, guys? Go ahead.
دكتور سؤال واحد بس من ناحيه الليتنت تي بي. اذا البيشنت كان عنده البوزيتيف سكرينينج تيست but without signs and symptoms نعالج latent TB?
Yeah. If it's positive screening test or if it's negative and active exposure كلهم latent TB. بالمحاضره بكره بقول لك latent TB اذا البيشنت جاك وعنده positive screening test بس ما عنده, the first thing you do check for symptoms. ما في symptoms يعني البيشنت is asymptomatic, he doesn't have active TB, you treat him for latent TB سواء HIV وغير HIV.
واضح